is here to stay. We've seen it emerge as a critical tool in the delivery of care, especially during the pandemic. And we all can agree that by no means are we, unfortunately, not in the post-pandemic era just yet. Now, smart agencies actually have been using telehealth, and whether it's for virtual visits, secure messaging, assessments, or remote patient monitoring and care management for a number of years. Some agencies adopted telehealth in advance of PDGM. Remember when we thought that PDGM was going to be the thing that keeps us up at night at the beginning of 2020? That's before the emergence of COVID-19, right? So telehealth is not just a stopgap. It's not just something that, oh, you did because patients were quarantined, because there was the risk of infection and transmission. No, that's the old model of home care. The new model of home care really leverages the information, the insights that technology brings to really complement what you can do as you're part of the spectrum of care. Today, I am honored to co-present with Dave Davis, Chief Clinical Innovation Officer from Accent Care. I am Ana Maria Toronto. I'm the Chief Marketing Officer of Cinzy. Cinzy was launched in 2018 as a telehealth and virtual care platform, and in 2019, we focused specifically on post-acute health, such as home health, home care, hospice, SNFs, ALFs accordingly. So technology, it's changed how we live, how we shop, how we travel, how we worked, especially this past year, and it really sets up an expectation going forward. So when we think about, the statement that I started with, which is telehealth is here to stay, it really reinforces the idea that Bill Dombey presented last night, that he said healthcare, especially home health, hospice, and home care, is increasingly high touch and high tech. And what it does is, from a technology standpoint, it puts the consumer, mind you, I use the word consumer, I use the word individual, not just patient. It puts people at the center of the infrastructure for technology. And what that does is it drives a better sense of efficiencies for an organization, for the top and bottom line, as well as the experience for not just the patients themselves, but also the family caregivers, your clinicians, your staff, your administrators, et cetera. So when we look at the origins of telehealth, what's really interesting is that it's been around pre-pandemic for decades. In fact, these are just a couple of the milestones of the early uses of telehealth. And some of these you might be aware of them, some of them you might be surprised by. And at the very beginning, telehealth was useful, especially in rural communities, in connecting patients and families with resources in areas where they didn't have the specialty necessarily covered. Now, actually in 1924, there was a publication called Radio News. Imagine that. And on Radio News cover, there was an illustration of a radio doctor. And that radio doctor was depicted conducting a patient call with live sound and live video. And that's really the first kind of illustration that's out there of what telehealth could be, as well as what the delivery of care can be going forward. Now, the delivery of care and the use of telehealth has moved from not just rural settings, but also for urban, major metropolitan settings, suburban settings, et cetera. And what we're seeing today is that it applies in a lot of cases. We're not yet at the point, as Bill Dombey pointed out yesterday, that surgery can be done, in the home health setting using telehealth, remote patient monitoring, but who knows, someday. We have to collectively reimagine what the delivery of care would look like. And that means addressing and answering a couple questions for the patients and family caregivers that you serve and that you support. Number one is, what are their experiences? What are their expectations in using technology overall? What is the implications for how they want to access and receive health care, especially at home? Number two, what about your employees, current and future? Workforce challenges and staffing remains a top priority for most healthcare organizations, especially those in the post-acute care setting and spectrum. So, being able to offer virtual care, telehealth, not only positions your agency or organization as being forward-thinking, but it also reinforces that flexibility that today's workforce is expecting from their employer of choice going forward. Number 3, another question is to consider, what is your competition doing? And what does your referral sources want? The physicians that you work with, the hospitals you work with, the SNFs that you work with, what are they expecting from you? What they're expecting is results. They're expecting outcomes. They're expecting improvements, and they want to see the data around that. They don't want just the stories. And that's something that we're going to share today, which is what is the data that's going to be impactful, especially as you continue to arrange value-based purchasing agreements going forward. And then last, thinking about the healthcare ecosystem. What is the right balance of in-person versus telehealth provided virtual care, and how does that hybrid model sit today, and how will it sit tomorrow in your organization, especially as we hopefully move into a post-pandemic era? Remember the early days of COVID? Feels like we're kind of regressing in those early days as well, right? I think regardless of your vaccination status and whatnot, probably we were all still carrying around the masks long after those mask mandates were dropped, and sure enough, the mask mandates are back. So good things we didn't get rid of them. But from the patient perspective, it was some dark days, especially in the early months. When we think about the rising risk and high-risk patients who are at home, are lonely, are isolated, their loved ones can't go to visit, and their loved ones, as well as the patients themselves, might be essentially cutting off their access to the quote-unquote outside world, which includes home health agencies, hospice agencies, and home care agencies, because everyone was fearful, worried about the risk of infection and transmission. And it wasn't just the home settings, it was also the SNFs, it was also the ALFs, et cetera. So this forced agencies, organizations, and facilities to say, we still need to remain connected to our patients. We still need to think about how can we continue to serve them in a way that's best for the patient, but also it respects what the clinicians want too. Because the clinicians, your employees, your team members, they were equally worried, if not more so than your patients, because they have a role, they have duty of being out there in the community and continuing to fulfill their duties. You know, whether it was home care, hospice, home health, et cetera. They're anxious about the risk of infection transmission. They're worried that A, they don't have enough PPE, B, they don't have the right PPE, C, they're afraid they don't know how to appropriately don and doff also the equipment that they need to keep themselves, their loved ones, as well as the patients and family caregivers that they support safe. So they want to stay in touch. They want to safely provide care. And organizations who quickly basically turned on telehealth in this regard, even if they were using telehealth to begin with, really started off by saying, wow, we can push educational messaging. We can do this from a broadcast standpoint, and what it does is it really saves valuable manpowers in terms of the hours, the labor, the effort involved, and of course the cost, the bottom line, that you could send out messaging to your daily census with WHO videos, CDC guidelines, reminders of remember washing hands, as well as wearing masks, social quarantine, et cetera. And that's what a lot of agencies did. Like, for example, they would use the Cincy platform to do that. And they said, you know, it really helped us communicate that we want the patients to be doing the right things for themselves as well as their loved ones too. And then it took it to the next level, which is not just we're giving them the factual information, but now we're also recognizing that they need some emotional support too. They need some compassion. They need to know that we're here for them and we care for them. And a lot of agencies actually position the use of virtual care and telehealth as something that allows a patient to feel like they're a VIP, that they're organization that's providing care in the home for them is actually thinking of them almost 24 hours a day. Maybe it's sending them a message once a day, a couple times a week, maybe frequently too, depending on the condition that they have, as well as the risk in terms of rehospitalizations and trips to the ER. So this allowed agencies to essentially keep in touch, continue to engage with their patients, continue to keep them happy, keep them satisfied, and most importantly, continue to the enhanced outcomes, especially if they started working with these patients pre-pandemic. The response has been overwhelmingly positive. And hopefully for those of you who are using telehealth today, you're seeing and you're able to express similar sentiments in terms of being able to use telehealth and virtual care and recognizing the results that you get from it, both from a qualitative and quantitative standpoint. So for example, Jamie Sommerfeld, VNA of Midlands, President and CEO, at the beginning when he started using Cinzy, he actually said, we have a responsibility. We need to be in the community. We need to continue to support, deliver the care. And telehealth enables us to do that. And VNA, they also support a lot of under-resourced individuals, shelters, people who are in between stages in their life, young mothers who need advice on parenting skills and whatnot. And this allowed them to visually connect and continue to engage with the community, not just the patients that they serve. And then the other quote on this page is from the CEO of Excel in Home Health, Alicia Marr. And Excel in Home Health has a number of agencies within Texas, California, and a few other states. She said what was so impactful in terms of the use of telehealth during the COVID situation was when it came to hospice care. Bill Dombey yesterday night talked about how everyone who has used hospice for a loved one before usually has a very positive experience with it. And therefore, the sentiment towards hospice is very positive. So you could imagine people's potential resistance when all of a sudden everyone starts talking about telehospice. But quickly, the loved ones, the patient, the organizations who are using it felt this is the right thing to do. In fact, this is the only thing to do, because how else are we going to bring near and far family members in touch to discuss the appropriate actions with their family members, as well as potentially having to give them, say goodbye to their loved ones as well via video when visits were restricted, or they couldn't even fly given some, scheduling and the risk of infection and transmission. The hospice situation is also important after the fact. So after a loved one passes, telehospice also enables the family to continue to receive support, guidance, counseling during that bereavement period in a much more convenient and efficient manner for all involved. So it kind of lives on, if you will, in that regard, that it's not just for a period of time up until the unfortunate event, but it also continues to pay it forward too. And then last but not least, Alicia Marr has said, and this is one example of how they use Cinzy, in addition to hospice, is the use of digital assessments, essentially patient surveys. And they use it not just for their patients to check in with them about their conditions, as well as screen them for potential risk of infection or transmission of COVID. They also do that for their employees too. We do that internally at Cinzy every day, that everyone has to give the temperature, fill out a quick survey, make sure that if there's any emerging symptoms, they're flagged. The dashboard reports that accordingly, and the appropriate actions can be taken. And if someone is quarantined, or someone unfortunately is going through COVID and whatnot, the assessments make sure that the organization is aware of when, if, how it's appropriate for that employee to go back to work and return to work in that regard. So the feedback has been overwhelmingly positive from the patients and families as well. Very emotional. People say, wow, this is great. I can't believe we haven't had this before. For patients who use it for physical therapy, this has been very enlightening because they're able to still continue to do the exercises, get the guidance from their physical therapist as to if they're doing it the right way. In fact, we have some physical therapists who have said, they start the session with music, it kind of like draws someone a little bit out, almost as if they're going to start dancing, which they're not. That's not necessarily part of the PT protocol. But it really gets the patients who have been home, have been, experiencing all the social determinants of health, right, that we can imagine. And it gets them excited, engaged, and again, they realize that someone is looking out for them. Your organization is truly caring about them and making sure that you connect with them as frequently as you can. Clinician feedback. This is really the quadruple aim of healthcare come to life in many regards. You think about the triple aim of healthcare, right? Less costs, better patient health, better patient experience. Quadruple aim. The fourth is, what about the clinicians? What about the satisfaction? And satisfaction, if it's not there, that's going to obviously impact your ability to recruit and retain the talent that you need to be as successful as you can be. And clinicians look at this and say, thank God we had it. Fortunately, our organizations either put it into place very quickly within a day, or they had it to begin with because they were prepared for PDGM with it, and we were able to roll it out and continue to care for our patients in a timely and safe manner.
And good morning. I'm Dave Davis with Accent Care and sit as their Chief Clinical Innovation Officer. Wanted to kind of share some of the experiences that we had with our expansion of telehealth into the home. And I call it an expansion because we had started this, as Ana Maria was just talking about, prior to the COVID emergency. So I'll give you a little bit of where we went and then come back as far as what the background was as far as accelerating that. But what you see on your screen right now are two applications. These are white labeled applications that we deployed through the Sensi platform. So you can notice that they actually have our logo on it. Our naming and branding has been put into this so that the patients recognize it as part of the suite of services that they receive through Accent Care. The first one is My Care Team, which of course is the patient-facing application that can be downloaded onto any device. The second one is My Patient, right, which is our clinician-facing application, which they can then, manage their patients through use of that type of application. I'm going to stand here a little bit with egg on my face and say that I was one of the big naysayers at first that said our home care patients do not have the ability to use this type of technology routinely, and then I got proved completely wrong. In some of the other applications that we have launched in the past, patients were not able to do that. However, because of the COVID emergency and everyone knows how this accelerated so quickly, they became very astute with these type of interventions, right? So whether they were seeing their primary care, their specialist, or others, they were using similar type of technology, and many of them got very accustomed to it, very used to it. Their caregivers got very accustomed to it. As a consumer of home health and hospice with my parents, I got very accustomed to it because I really enjoyed not having to load them up and take them into a potentially COVID-infested environment and then bring them back into the home, right, prior to immunizations and all these things being ready. So it was a little bit of a learning curve even for the innovation officer at Accent Care, but I will tell you that it was very successful. And just going to try my best to move through here. But this was sort of our approach, right? We had actually started using the application in a different manner. What we were doing at the time prior to COVID was allowing our bedside clinicians to connect with a wound care specialist on demand or by appointment, right? So this would help expand those critical resources, those expensive resources, not necessarily having the wound care nurse drive 300 miles during the course of the day so that they could cover all of southern Mississippi and the other one covering all of northern Mississippi and somebody covering half of South Texas and all of the rest of this. but rather be able to do a wound care consultation, with that specific nurse at the bedside, guiding the patient through the assessment for sleeping surfaces, for sitting surfaces, for dietary restrictions, for vitamin supplements, for all of the things that the specialty wound care nurse will be doing, as well as validating all of the clinical measurements and type of wound and all of these things, right? So what we found, was that our nurses just loved this idea, because they would have an expert being able to be pulsed in at any time. So we had a group that we had just expanded prior to COVID. And again, if you guys may recall, initial COVID sort of began those first couple of cases towards the end of January of last year. So we heard about these cases. There was a little bit of rumbling, we're thinking this is going to be very similar to some of the Ebola outbreaks and things like this, where the CDC will confine everything to a hospital. That didn't happen. It was immediate as far as understanding the community impact of this. And we said very quickly, we have a platform in place. It's not launched quite yet to all of our clinicians, but we've got to get it out there to all of our clinicians for various reasons, right? We have to be prepared for the pandemic. We have to be prepared to meet the resistance of people who need care in the home, but are going to refuse care in the home. And it is, a wonderful, a good feeling to know that we had, sort of been on top of this a little bit before this, although it was still a huge lift coming in between the end of March and April to move all of our clinicians nationwide to have this type of access and to set up the systems, that are necessary in order to get them trained, to get them comfortable, et cetera, with this. So, what we knew going into this is we wanted this to not be a flash in the pan. We wanted this to be an integral part of care planning for this patient. Not saying, Ms. Jones, you have COVID, so we're not going to see you, right? We wanted this to be, Ms. Jones, it is our routine for our COVID positive patients to do this admission, and then we will follow you for days, this way. And then we will do another, in-home based intervention with you, again, to prevent the spread of illness, both to our clinicians and to other patients in the community. The second was, being able to say yes to our hospitals and other partners. Because I said, this came on very quickly. Hospitals filled up immensely fast with this. They had to go somewhere. As you guys know, no one was dying to go into a communal living facility, whether that was a SNF or an AL or any of these other type of communal, facilities, for fear, right? So the best place to take care of that patient, proved to be at home. And what we knew is that we needed to help get those patients from that hospital environment into the home environment safely and effectively and as fast as possible. The last thing, and this is probably the reason that that I wanted to bring this up in front of the financials managers, which is we knew we had to do this whether it was billable or not, right? And so nobody throw anything at me, but what I mean by that is you can fit this into traditional episodes, right? Again, if it goes back to your care planning and it becomes a routine for you, it fits under episodic payment, it fits under hospice per diem payment, it fits under those type of things. And as we go through the rest of this, I'll show you some of the things as far as advocacy for those that were progressive with their managed care payers, and those managed care payers that were also progressive in return, who began to recognize the value and then allowed for payment for some, under certain circumstances for this within the home. So it's, it was something we knew we had to do because it was the right thing for the patient. From our CEO's perspective, and as the chief clinical guy, when the CEO talks, he's basically telling me this is what you need to get done. So this was his perspective. He said, he wants to reduce the burden on the nation's hospitals. So again, we knew how important this was. It's going to become very important again. Everybody sees the news, they see the headlines, we know what's coming. Hopefully it will not be nearly as tragic as the last, surge and losses that we've had, but there are going to be surges and losses, and there are going to be people who need to move from a hospital environment to the home just to get the adequate throughput so that someone else can be cared for in the right environment. We wanted to make sure that there was that we were able to safely answer the call. So Ana Maria said it very, very poignantly. You know, clinicians were afraid, right? They knew that this was a very significant threat to themselves, to their families, what they bring home, what they bring from one vulnerable patient or immune-compromised patient to the next is counterintuitive to everything that we learn in nursing school, right? It is counterintuitive. You always protect the patient, right? You protect yourself, you protect your patient. And so we had to make sure that what we launched was a safe environment and that it helped reduce the risk and spread of infection. And we wanted to deliver impactful care virtually, not just during COVID, but again with a very long-sighted understanding that this will become part of our future. It will be, as Bill Dombey talked about yesterday in the Choose Home legislation, right? It's required. You have to be able to offer something like this if you're going to participate in that program. So it is not a nice to have. I really feel like it will be a need to have. And then what we learned here was identifying gaps in care, right? And here's some of the gaps in care that we found to be very helpful with this type of platform, aside from that routine care planning, because we knew in routine care planning, you can do medication teaching through a virtual platform. You can do assessment and observation of many different things through a virtual platform, right? So all of the things that are Medicare skilled, you can do symptom management oftentimes through that virtual platform that are hospice skilled care needs, right? So there are many different things that are very innate to what that allows. But then we started identifying other areas, right? One, of course, like we talked about, was wound care. We knew already that was a deficit for, I would say, our organization, but also as the industry, right? This is one of the shortest of pools to choose from are those WOCNs and those true wound care experts that can consult. Personal care services, supervision of personal care services. We have a very large personal care platform. Some of our cities, like New York, was one of the, obviously the hardest hit, but this type of virtual visit intervention and being able to supervise the care aides and again push out information to them that protected them and their safety and allowed them to report what was going on with their patient so that we would be able to respond appropriately was very, very significant. The after hours and triage abilities for this are tremendous, and I'll talk to those about the hospital reduction program on the right side of the slide, but one of the things that I will come back again and lessons learned again from the clinical guy here, had a physical therapist working with me on the protocols for how we would deploy the virtual visits and what they would look like and what the documentation would be, et cetera. And we said, well, there's no reason to necessarily set up speech therapy as a virtual visit in the system. We couldn't imagine how someone would be virtually teaching someone to swallow or communicate. To which I got calls from speech therapists, one very loud one who said, Dave, I just completed a virtual visit on the physical therapist tablet because you didn't put it on mine. And I said, well, what did you do? And she says, it's very difficult when both people are wearing N95 masks to show people how to speak again. She says, I sat in the driveway, I took my mask off, had the patient take their mask off, and we were able to actually have a very significant speech therapy intervention with this patient for the first time in months, because it was just ridiculous to try to sit here mask to mask and try to teach someone where to put their tongue or how to shape their lips. So again, an epiphany in my book. Don't limit this to what you think is there. Go to your staff, ask them, right? Make sure that they're helping guide what this is, because now all of our speech therapists have access, and there's some of our heavier users of this, because again, as you know, as healthcare workers, we're still mandated to wear masks in the home, and it's very difficult to be able to train someone that way. And then as I talk about the next one, which is our hospital reduction program, this was very heavily tied to our triage. And what we found was after hours, if we give this power to our after-hours central triage nurses, and we said, what you're going to be able to do is drop a link to this patient or their family member when they call in, and they tell you that they've fallen and they've got a skin tear, or they've fallen and they've got a bruise, or they're not able to do X, Y, or Z, right? Then we want you to be able to deploy this type of technology to help this patient so that we're not moving them to an emergency room unnecessarily, sending them back to their doctor unnecessarily, sending them to urgent care, whatever the case may be. So one of the things that we immediately found was wound care, right? You can get a picture, not a still picture, but the nurse can get a video representation, right, for which he or she can make a determination of what to do with this wound, right? Is there cellulitis present? Is it going, does this require a doctor, or is this an urgent situation, right? The same with infusion. Something as simple as the patient forgot to unclamp the tubing, which would have taken a nurse 2 hours in the middle of the evening to go over, drive out to the on-call nurse, unclamp the tubing, and come home. It's a waste of time. It's a dissatisfier, and God knows we need all of the staff that we can get, so we want to make sure they're very satisfied. Gastric tubes, same thing, very, very simple interventions that can be taught once you know what's going on with it. And the same with new diabetics, right? So they're able to demonstrate back to the nurse the next time that their insulin is due. The nurse in triage can actually say, I want to see you inject your insulin. Show me what you're doing. Show me how you're taking your finger stick glucose. And it works tremendously without having to deploy as many nurses on this. I cannot tell you what a clinician satisfier that those type of interventions have made. So one of the things that we decided to do as we launched forward with this was to study it. And I just cannot tell you guys how important it is if you decide to design your own types of virtual visit interactions, that this is going to be very important, and I implore you to add to the body of evidence that supports the use of virtual visits in telehealth for various reasons. One is for reimbursement purposes, because we will need to go back and ask for reimbursement, right? I mean, I know we've got things like the HEAT Act and other things like this that are pending legislation that are emergency-based. However, to make this more permanent and actually get reimbursement, people have to understand the value of it, and unless we're documenting the value of it, it's not going to do us any good. But again, what we know, right, was payers began to broaden their coverage a little bit, right? So there were some that began to allow some Medicaid programs, some commercial or MA programs began to allow this. One of the things that we did was partner with BKG, Britain Kalish Group, and studied what we were doing with Accent Care and what that looked like as far as patient outcomes, what it looked like as far as the demographics of this. And our goals for this study was to track the outcomes. Our hope was that they would be equivalent or better than what we have with just a visiting group, right? As opposed to somebody who we called a hybrid group, which got both visits and telehealth interventions at basically the same frequency. There was about a 1 visit difference in between, or 1 encounter difference, I should say, because there was 1 more on average virtual interaction with these patients whenever we saw it. So pretty equal when it comes to that. And then really provide that compelling reason to go back to Medicare, to go back to our Medicaid services, go back to insurances and ask them for money for this type of intervention, because it is definitely something that is proving itself to be worthwhile. What we ended up with, and these are high level, and then I'm going to go into a little bit more detail, but what we did see were that we had improved patient outcomes. Inpatient admissions were reduced significantly, and a very positive, almost equal to what the in-person visit, actually a little tiny bit better than what the in-person visits were. So this is our program outcomes. These are being peer reviewed, hopefully will be finished by the end of next week, and looking to publish on these, but just so you can see our hybrid group, those are those that had at least one type of virtual visit during the course of their treatment with us between May and June of 2020, okay? We're over 314 participants in that. The traditional group received only routine visited home care, and that was about 1,000, and the comparisons are below. So you see with our percentage of hospital admissions within 30 days, there was a 5.7% difference. Now I want to talk a little bit about the demographics of this. They were almost identical. Equal number of persons in each group were female, more heavily female than male. Equal number of, in terms of race, in terms of socioeconomic status, in terms of the way that we, sort of divided these out, they were very, very, very similar. And the one thing that I will tell you is the confidence interval on this study is right at 99%. So it is extremely wedged in evidence, right? And that's at a p-value of 0.086. So for those of you that are statisticians and love that kind of work, just understand that that is a very high confidence interval at that level and shows that it is definitely something that is worthwhile. The hospitalized within 60 days also held true at about 3.9%. Length of stay was relatively equal. So again, between the two groups, we saw significant reductions with this. Then overall, some of the things that I'm proudest about, and proudest about because I'm a nurse, so if there's therapists in here, again, don't throw anything at me, but you've had a lot of focus on your outcomes, right? You've had a lot of focus on the dressing of upper body and ambulation and transferring, which are all very, very important outcomes. But two things that nursing, I feel kind of belong to us, right, are the management of oral medications and the relief of pain. And if you notice in here, these two outcomes significantly improved with this type of intervention. So 16% increase in the ability to manage the patient's oral medications on their own or with the family. And then a better outcome, 11.4% increase in getting pain under control, pain that is no longer interfering with the patient's activities of daily living. So overall, the total combined was a jump of about 6.7% in the actual patient outcomes. Patient satisfaction reporting. We also thought, well, here's Dave telling everybody that these elder people and disabled people don't like to use this type of technology, so you better check it out and see what happens. Well, here we are, right? They actually like it a tiny bit better. 96% in positive as opposed to 95% positive for our virtual visits. So really, really happy with the outcomes on this. Hopefully you guys will see them pretty soon. Wanted to introduce them to you here today as part of this. And the virtual visit platforms that Cindy and others have provided for us are really what has enabled this. But I also want to talk again, I know Anna Maria did it, but a little bit about staff satisfaction. So these came from our actual clinicians within Accent Care. Many of our clinicians, and I talked about New York, right, have to ride public transportation. There's no other way, right? In the city of New York, you don't get around any other way, which was dangerous, right? I mean, it was dangerous during the COVID surges and especially the rapid onset there. So they felt it brought efficiency, okay? It helped them to manage to see those patients that they had to see versus those that they needed to just do routine work with that could be accomplished through a virtual visit. Many of our nurses, because we allowed some flexibility in their schedules to allow them to decide when they wanted to take a block and do virtual visits with this, found the flexibility very, very nice. And especially, again, we're talking about folks who had lost daycare, folks who had to be juggling their family at the same time as juggling these jobs, felt a purpose, felt a call to purpose to go see these patients, to take care of them, and many of them found a way, right? As all of as all of our smart parents do, right? They find a way to make it work. They feel good about being able to give someone moral support. So more than just teaching about medications, right? Felt like we were outreaching to these folks who had been isolated, who remain, in many ways, still very shocked and traumatized, from a behavioral health perspective over this, and to alleviate some of their fears and give them actual moral support to know that they're seeing their clinicians, those folks that had established a relationship with them, during this time period. And then my favorite story here, and again, it's shame on me for my assumptions and presumptions, but we had a husband and wife who were both released from the hospital, both COVID positive. Luckily, neither had to be ventilated. Both were over 90 years old. They were released to the home, into our care. And again, just sort of introducing them to our new norm as far as our care planning, which included these virtual visits. They were very accepting of it, a little bit leery of how they would perform with the technology. So the nurse took their time on that visit, knowing that they were going to make up time in the future, right? That this was not lost time. This is time that in the future the visits will be much more efficient because there's not going to be as much windshield time, right? There's not as much travel time. There's, streamlined documentation and all the other things that we've done to make this work, right? But they successfully completed each 7 virtual visits during the course of their treatment without a problem. All they had to do was turn it on and the nurse was there. So they were very, very satisfied. It really was a win-win, and it was a good story to tell our entire organization to help get them moving. So a lot of other things, here, being able to see my dad, right? Again, we talked about, airlines, being unable to fly in, people not being able to see folks because they were worried about bringing infection into the home, et cetera. The first call brought tears to our eyes. It alleviated much of the anxiety for my dad and for me. And you are superheroes. So I'm going to stop there and let Anna Maria pick up again. Thank you.
Thank you, Dave, for highlighting both the obviously physical manifestations of how virtual care telehealth works, as well as the emotional benefits for everyone involved, all the key stakeholders. There's a lot of benefits of telehealth. And I think, if we look at the diamond, that's what everyone should focus on. It's improving that quality of care. It's thinking about how do we take care to the next 2.0, 3.0, 4.0 level, et cetera. And part of that is the timeliness of being able to immediately, on demand, connect with patients, as well as making sure that they're engaged with the appropriate specialists, whether it's wound care nurses, whether it's someone from hospice, it's therapy, behavioral and mental health support, even it could be the referring physician. It could be the pharmacist, as well as medically certified interpreters, to make sure that the patient truly understands, is engaged, knows about his or her role in self-care, along with how the home health agency, hospice, or home care agency is going to continue working with them going forward. So a couple things in terms of the gaps in care. I just talked about how that it makes up for, the demand on especially those resources which are scarce regardless of the communities that one lives in, the communities that they serve, as well as the LEP patients. There's many patients that you have, right, who their primary or preferred language is not necessarily English. How can you take care of them appropriately if they cannot understand what you're saying, what you're communicating? How can they take care of themselves or their loved ones also support the mission that you're trying to carry out? And your referral sources can trust you inherently if you have what's needed to make sure that their patients are truly going to be heard, going forward and not just seen in many regards. So telehealth really covers all patients anywhere at any time. It is kind of, something that just goes across all patient populations. And as Dave alluded to, it's not just for the young, it's not just for those of us who use technology in everything we do day in and day out, but it also goes up into those who are in their 90s too, who are embracing technology and virtual care. So I wanted to give you another example of telehealth from a physical therapy example. Working with an agency called Concierge Home Care. They're out of Florida. They're, have leadership. Their co-founder and CEO, Linda Murphy, is forward-thinking, innovative. She started working with Cincy before PDGM, and obviously stepped up efforts with virtual care and telehealth during COVID. And for her, telehealth, it's not that it's here to stay, it's where was it many years ago, right? But what they've seen is that for total knee replacements, they moved from a model that was 16 in-person visits down to 9 to 10 in-person visits. And now with virtual care and being able to use virtual visits, they do a hybrid where it's 3 in-person, 3 virtual visits. They're able to get the same, if not better, outcomes, as well as greater patient satisfaction and greater satisfaction, trust, and better, deeper, stronger relationships with their referral sources too. And that means it's fewer setbacks, it's less rework. The patients are happy that someone is there for them. And as Dave pointed out, that teletriage is really important after hours, weekends, and holidays. What you want to do is make sure that there's peace of mind for your patients and their loved ones. And if something can be addressed readily, saving the time, effort, the risks, the liabilities, et cetera, for sending a nurse on demand out there, especially in rural communities, you're really doing the right thing for the community, the patient you serve, as well as the people that you employ. I'll turn this over to Dave to wrap up, and in advance of that, I do want to thank you all for being here today.
Great, so now we thought we'd give a little bit of an example, and I call this section My Lessons Learned, that I can share with you, because getting started was not terribly easy. Staying started has been even worse than easy. It's been worse than not terribly easy. But here's the things that if I were taking notes on this from this with the intention of being able to bring up this type of program, this is where I'd start. And I actually would start with the last two, the bottom two here, which is number one, establishing a champion. That may be a regional champion, depending on what your organizational structure is. Most of the time, it's going to require a local champion of some kind. So however your organization operates, if it's a single agency, that's great. If you've got multiple branches under there, that's great as well. But understanding that likely you're going to need a champion at each site. And this is somebody that can keep their eyes on the prize for you, because there are going to be folks that are naysayers. It goes against what we've done always, right? Without bringing up any names, I'll just, home care was born of, visiting nursing, right? And so what I'm telling you is this doesn't always have to be a visit, and it doesn't always have to be a nurse. And that's a little uncomfortable sometimes for folks to embrace, right? So it's just a little bit different, and you're gonna have to have somebody inside that's dedicated to keeping that going for you. And then making sure that your leadership is in line with communicating. This is a huge must about what's in it for me, right? These nurses will oftentimes feel, and I'm picking on nurses, but it could be any of your clinicians, will feel like you're taking visits away from them, right? That this is not the way that they wanted to deliver care during that time. And it's a change management process, right? This is not a one and done, and I'm going to tell you this is how we do it, and this is going to go, right? Because that's never, ever worked, ever. In 28 years of home care, I've never seen it work. I've always seen it backfire. And the truth of the matter is we have to show them what's in it for them. It was a little easier, to be honest with you, when we were talking about self-protection patient protection, those sort of things. So it's a good time to strike while the iron's hot when it comes to something like that, to let them know this is available and get them used to and comfortable with that type of pace. But then show them the literature, right? Use these type of studies, use your own internal studies. You don't have to go pay for somebody to do, the computations on peer-reviewed literature and that sort of thing necessarily. But again, I implore you to definitely look at collecting your value proposition around this for both internal purposes and for external purposes. Then what I would tell you is focus on value versus volume, because it's not the number of visits, in case somebody has lost that over time, right? We've proven that multiple times in home care. The number of visits is not what achieves an outcome. It is the value of that visit. It is the exchange of information. It's the learning self-care techniques and the other things that are necessary for this. It helps push people a little bit to work at what we always talk, the top of their license, right? And you can achieve value through these type of visits far beyond cranking out, payable visits, right? The other, right, thing that I always tell people in regard to that is it fits really well under certain reimbursement categories, right? If you do have payers that are willing to pay for it, do it. Use it there. It works really well under episodic, right? If you're above, if you're above where you want to be in your total visits per episode, look at how many could possibly be replaced by this. You will see a cost savings. There's no way you can't, because you can do more encounters to achieve the same outcome in less amount of time. So it's just a simple equation that way. And then get patients excited, have a campaign around it, let them know that this is an extra type service that you've invested in, and that it is part of your care planning. It's part of modernizing how we do care for them. It's a way to bring their caregivers in more often, right? It's a way to make sure that they're able to interact and get all of the type of services that are necessary. Use those examples of teletriage. Somebody's going to be there to answer your question, right? Somebody's going to be there to be able to put eyes on you. So for as many years as we've been posting things on the refrigerator saying, call me first, and don't go to the ER unless you called your nurse and all this other stuff, it doesn't work. Because people, if they believed you, they would call you, right? If they trusted that there was going to be somebody to do this, what you have to do is ask them to test you. And you have to make sure you step up to that test. And this is one way that you can step up to that test and say, I'm calling the answering service because I'd like to see what a video visit would look like if my mom fell, right? Simple thing to do. It's a really great thing to do from a customer service perspective, and it really adds to sort of that campaigning around this. Pick what you think your success measures should be, right? What will you track? These are some examples. You may find many, many others. We could go on for days with any number of metrics as far as how long did it take for that teletriage call to get back in, and measure everything to death. But pick which ones are important to you, right? These are broad categories, right? Your readmission rates. Maybe you want to focus on a specific diagnosis grouping first, right? Maybe which ones are the ones that are rehospitalizing more for you. Okay. And then sort of the future here, what do I see as next for telehealth? I truly believe, right, we have the responsibility for offering a VIP level of care that will include this as part of routine care planning for patients, that it becomes part of their actual plan of care when it's written onto the old Form 485, right, or into that hospice plan of care that has truly the number of visits that we prescribed in terms of setting foot on site as opposed to being virtual. That's some of the language in the COPs that changed, right? It's not quite there yet, but I think once we do that and it begins to be codified that way, then there's a lot of tracking that could be done that would show CMS the benefits. So I definitely think that that's the way to do it. But the way to get the patient buy-in and others is to make sure that they understand this is a higher level of care that your agency or your organization is offering. Explore reimbursement beyond the physician's office. So again, be advocates for things like the HEAT Act, but also looking further down the line, contributing to the pool of research, of literature, just your own studies so that you know what this looks like, so that we can ask for reimbursement outside of what the physician fee schedule is, for those doctors. Getting to a point where we have, beyond virtual visit functionality, right? Things like this pulsing of information to patients. We've used this platform, just so you know, for emergency preparedness, to alert a specific zip code that there's, a gas leak, right? We've been able to tell the entire coast of Texas, that you should be preparing for a hurricane now. Here's your list to make sure you have everything in place, right? Saves hours upon hours upon hours of people calling on the telephone going, do you have canned goods in your home? Are you planning to stay? Where are you going? What's, all of these questions that we have to get through in just a matter of moments, right, during an emergency. Include alternate people, right? Think outside of the box, include alternate people. We are now beginning to do virtual consultations with clinical experts. So I have a certified heart failure nurse that is able to be pulsed in. I have a certified diabetic educator that's able to be pulsed in, a nutritionist, a dietitian, right, who's able to be pulsed in on these type of visits. And while we're starting very small in one region, it's very manageable for them because the demand for that has not been enough to keep people extremely busy. And sometimes I think we create demand. But your routine nurses know when they need help, and if you pulse them in like we were talking about with the wound consultants in that similar manner, then we found that to be really very helpful. And I did not write this last one, so it must have been Anna Marie, but I love it. It's to get rid of the tele in telehealth and understand that this is the healthcare delivery. This is a part of healthcare delivery. It should be no different, right, than how we visit a visit, or how we envision a visit going and how we complete that visit with a patient.